We're good to go.
Bring you on over here. Does that work for you?
And the sound should be great.
Testing 1, 2, 3. Responding?
Yep.
You good?
Good to go.
All right. So we're going to talk today about my favorite topic, which is stellate ganglion block for PTSD. So I thought I can give a history of how it came about, and we can talk about the latest studies and so to speak, where we are at. Hello. Hello. Jesus.
Oh, the host just messed up.
Oh, well. Anyway, so could you turn off your phone? Could you please do that? Would that be possible, you think? Or we need to surgically remove it?
Give it a shot.
Decapitate the dog.
He's already reduced it by like 5 ringtones.
Cut and burn. Cut and burn.
Anyway, back to stellate. Okay. Anyway, so the first time stellate, at least when I started using stellate ganglion block for non-typical indication, which is usually the indications are CRPS, complex regional pain syndrome, and headaches, was in 2004 when I had a patient that had severe hot flashes. And I sent her to my brother to take care of hot flash. He's an internist. And he basically looked her over and tried to take care of it, and he could not. And he said, well, you take care of CRPS, which is a burning of the extremity. Why don't you do stellate for hot flashes? Because it's everywhere burning. I was like, I don't think that's true. Being an anesthesiologist, I know that doesn't work. And he said, try it anyway. So I tried it and it worked. So then we published some stuff on it. And Chicago Tribune came into my office and did a kind of fairly big interview in 2005. And when the paper came out, I knew I was in trouble. And the first line was, Bianca Kennedy, this beautiful breast cancer survivor, was so desperate to get relief, she let Dr. Lipov plunge a 3-inch needle into her neck. And it went downhill from there. So like the chairman of gynecology at Northwestern basically said it was dangerous and so on. So following that, they said, yes, it's working, but you don't know how it works, so we shouldn't be doing it because it's dangerous. So the whole logic of that is debatable, to put it mildly. So I was trying to figure out a paper, at least I was trying to understand how did the stellate work for hot flashes. So I read about 3,000 papers. So one of them, anything that was a unique utilization of stellate. So one of them was T2 clipping in the chest in Finland. They were clipping sympathetic fibers for hand sweating. And the hand sweating went away and PTSD went away. So I got very interested in that. So it turns out, if you look at the anatomy, so sympathetic fibers migrate from T2 up to the stellate and up to the brain. So I was able to predict that this would work for it. So I called up my brother again, and he had a patient who had severe PTSD because he was robbed. He's not military. So we treated him, and that came out. First paper came out 2008. So following that, it's kind of interesting how it's all connected. So then I was in Tribune again. It was a much better article then, in 2009. And then I wrote a mechanistic article, how it worked and all of that, how to link. Why did it work on hot flashes? Why did it work on PTSD and pain? So my wife said, it's like the reason I wrote the article, she said, one thing cannot do so many things. So I said, well, it does. So she said, well, fine, explain it then. So I put it together, and that's why I called it unified theory of stellate, from Einstein's kind of logic. He's trying to shove it all together. This was not that I'm nearly as bright as he is, but anyway, so that's how that paper came out. And then, so they wrote a paper, they wrote something about Chicago Tribune, and somehow it made it to the hands of Dr. Mulvaney, who you know. He called me up in typical SEAL fashion. He said, is it bullshit? Is it real? And I said, well, try it, see how it works. So that worked. And then he published a paper in 2010. So that's how he got into the special forces, since he is ex-SEAL. And so he's published a number of papers. Then Dr. Lina published one from, that was from, not Walter Reed, dang, I forgot the name of the hospital. It's in Hawaii Hospital. He was actually the first one in 2013 to describe treating somebody who was actively suicidal. And it took away that gentleman he was describing. He was 32 years old. His job was transport dead bodies from Iraq for like 2 years. So he tried to then kill himself by drinking himself to death. So they did a block on him, and he became non-suicidal in 1 day, which is pretty impressive if you think about it. So kind of speeding it up a little bit, so Dr. Mulvaney has been doing a lot of it and publishing in Walter Reed, and then now he's in private practice. So the reason we started doing right side, that's one of the questions people ask, why do you do right versus the left? So right side seems to be more dominant for sympathetics. Also, there was a study done by Dr. Librazan in 1980, and he showed that in PTSD patients, the right side amygdala, which controls the PTSD, that's anxiety controller, that seems to be much more dominant on the right side versus the left side. So that's why we do the right side. But Dr. Mulvaney has been switching. When the right side fails, he switches to the left side. And I've been doing that too. So when we do it like that currently, the technique that you're using and I'm using, and I think Sean is using and other people are using who are actually in it. So we do the right side. If it doesn't work, then we do the left side. So the right side seems to work about 80-85% of the time. And then of the failures, 50% seems to work. So that leads us to about 7% failure rate, which is, I think, pretty amazing considering the condition we're treating.
What percent did you say?
So 85%, I would say, when you do the right side only, when you do C6, C3, or C4. And if that fails, we do the left side, and that works about 50% of the time. So you're looking at 7 to 8% failure rate in PTSD patients. So, I mean,
And among the quote-unquote failures, do you still see some symptomatic reduction?
So failure, the way we define failure, we use PCL, PTSD checklist, which is kind of standard. So if it's less than 10-point drop, then we consider a failure.
Sure.
Maybe some, but you're talking about mild. So I'm not a very patient individual. So if it's like, I like to see a vavoom change as opposed to, I feel a little better. I mean, what's a little better? I don't know. What's 2%? What's 5% improvement? We're talking about significant change.
Sure. So are there being like before and after images of amygdala oxygenation?
Well, that's a tremendous question, actually. Actually, there was a study like that. That was published in ASA by American Society of Anesthesiology by Dr. Alkire from Irvine and Long Beach, California. The problem with that study, there was an N of 6, so it's very small. They didn't have much cash. And then so they used PET scans, so it was basically you label the glucose, and you can easily measure how much water goes in, which is functional MRI, and then glucose, which is just, that's the only thing that brain eats. So they were able to demonstrate amygdala deactivation following Stellate.
Excellent. In all of the 6 candidates?
No, of course not. That was about 70% success rate.
Still.
Yeah, no, but it was something meaningful.
Sure.
But the point is, it's scientifically, people are like, whatever. So actually, we're talking to NYU right now about doing functional MRI study. That would be kind of the definitive study.
Sure.
The one that was done in JAMA, I would say was not the best. The publication that was done in Tripler, that's the hospital I'm thinking about, in Hawaii. So Tripler, Fort Bragg, and Landheim in Germany. So they were trying to do 250 people. They were only able to find 110 people, which is interesting. You got 3 massive military institutions, that's all they could find. Sure. That's pretty weak.
Sure.
And they, for some reason, they did Stellate, and then 2 weeks later did another Stellate. Which is like, what? Why would you even do that? So, supposedly it was twice as good as placebo, but the study quality was, it didn't convince anybody, shall we say. So the next study, I've been talking forever, like there was a write-up from VA from 2017 looking at everything that's been out there. And the next study should have functional MRI component.
Oh, great.
So that's what we're trying. So we have a study now. We're just looking for money right now. It's a mere $3.2 million.
Sure.
Just pennies.
Are there commonalities between the people that don't respond to it, the 7 or 8% that you consider failure? There's nothing in common?
Not really. And you know, it's like sometimes is it technically bad block? Is that some kind of a thing? So I'll tell you what we do know. So here's an article that we just submitted, which is was interesting. We were trying to find out exactly what you're talking about. Can I predict based on history who's going to fail, right? Let's assume that. So what we found, what does not make any difference statistically. So we treated, in a year and a half, we treated about 450 people, and we had data that was sufficient to publish on 350. So pretty decent N. No, that's a pretty solid N. So we had 21 types of trauma. So out of 21 types of trauma, there was just very few patients that didn't, no statistically significant, but statistically significant ones, 19 types of trauma, all of them responded. Be it childhood trauma, be it sexual assault, be it military trauma, be it first responder, it made no difference. Male, female, no difference. Age, no difference. So 20 to 40, 40 to 60, 60 and older, no difference. So the point, it seems to work across lines. But we have not been able to, suicidal, non-suicidal, no difference. Drugs, no drugs, as far as psychiatric drugs, no difference. So it seems to work across the board, but we are actually working on some biological assessment tools that may be able to predict it. So.
I was going to wonder if like dominance, right side, left side dominance.
You mean right and left? The handedness you're talking about, or so handedness really has nothing to do with amygdala, as far as I understand, and the right side amygdala seems to be more active, but it turns out, like when I talked to the guys from NYU, there seems to be cross connections in the brain also. So it's so complicated, and that's why we want to do the study. You can actually have functional MRI and professional people actually look at it in detail. Right. So there is no, to the best of my knowledge, I cannot predict who's going to fail. I just can't do it. And it's like I just did a guy last week. I mean, he has the same anatomy like you, so technically it's very easy. So we did great Horner's immediate, right side, left side, nothing. Not a thing. Like, it's so frustrating. It's like, and sometimes I do like a day of 10 or 15 people at nothing. And sometimes I've done a day like I did 3, and all 3 I had to bring him back for left. Sure. I was like, what the hell? I was like, it's so annoying. It is so annoying.
Familiar with how your procedures are with this?
Sure.
You're saying with that case study that it was kind of ridiculous that they did it twice?
Yes.
In between 2 weeks, why? Because I don't know how your procedures go.
Normally, the way I've been doing it, so I've been doing it for PTSD since 2006. So basically we do the needful, meaning if somebody has symptoms, then we treat symptoms, right? If there's no symptoms, why are we doing an invasive procedure? I don't understand that logic at all. So the way the guys in JAMA did it, so they did Stellate, and then waited 2 more weeks, did another Stellate. So typically the way it works, somebody comes in, do an injection, and I had one guy, he's still 6 years out. He was on the doctor show with me 3 years ago. 6 years out, he's still doing amazing. 1 procedure. So that's all he needed, right? Some people need a couple, but usually the first one lasts typically, at least in my hands, and probably, I'm curious to see your impression. First one usually lasts a couple of months, maybe 6 months, maybe a year, and the next one can last for years.
That's exactly what I tell people, 1 to 12 months.
Yeah.
Why does the second one last longer?
Well, then so that's a great question. So the basic, I'll give you theory. Keep in mind, I have not been able to get money to really study it. However, I can send you the paper from 2009. So the whole theory is what PTSD is and what it's not. So I'll start with that. So PTSD is this amorphous, crazy description, post-traumatic stress disorder. What's disorder? I don't know. Nobody really knows what that is. So if you look at the predecessor to it, it has been Soldier's Heart was the first term for PTSD in the modern era during Civil War. Then there was shell shock from World War I, and then battle fatigue from World War II. So there's just people just using different terms. So I think a friend of mine, Frank Ogbergs, who's a very famous psychiatrist, he came up with the term Stockholm Syndrome. So he wants to change the name to PTSI, post-traumatic stress injury, meaning it was a psychiatric injury. That means you can actually diagnose it by some kind of scan, right? So it's real. So if it's real, people will be much more accepting to be treated. So if you have a broken leg and take an x-ray and you go, you got a broken leg, let me fix you. As opposed to, well, we don't know what it is, maybe it's you're hysterical. What does all of that mean? So what I think what happens when there is a severe trauma, sympathetic system gets activated. That's pretty clear. Fight and flight system is hyperactive. If it's active enough, based on your childhood, your DNA, epigenetics, whatever, we can talk about that. But if that's active too much, it produces NGF, nerve growth factor. Nerve growth factor is neurotropin, meaning it makes things grow. Sympathetic fibers are particularly sensitive to that. So if you take NGF and inject inside the brain of a rat, sympathetic fibers sprout, so they're sprouting. So NGF seems to travel from the brain to the stellate ganglia. Once it hits that, it promotes sprouting in the brain, which is extrasympathetic nerve growth. As long as NGF is present, that's maintained. So when you have extrasympathetic nerves, it produces norepinephrine. So if you take CSF or a fluid around the brain, and the patient has PTSD, you see increased norepinephrine levels. And as long as it's maintained, you have this persistent activation, whatever. So after the block, it does two things. Number one, it turns off sympathetic output. So now norepinephrine drops. So the time for norepinephrine absorption in the brain is about 10-15 minutes. So a lot of times we see a significant change rapidly, right? We see that.
Minutes.
But then, right, it's like, whoa, I can now take a deep breath, right? You've heard that, I'm sure. But the other part, the question has been, part of the big question in my mind is, why the hell does it last for years? Because local anesthetic is gone in 8 hours. So why does it have long response? So interestingly enough, when you put local anesthetic onto the ganglion, it reduces NGF, nerve growth factor. If you remove NGF, the sprouting goes away. It's called pruning, is neuroscience term. So if the sympathetic fibers go away, it goes to the baseline. So then it potentially can last for years.
Sure.
And then the question is, why do certain people have a response that you need to do 1, and some people need to do 10, right? So then that's because I think it happens, depends on the trauma you're exposed to. So if there's no trauma, everything's marvelous, you're not activated, right? So then you don't need it. But we had, I treated a 12-year-old kid after she was molested by a lovely gentleman at 6, and then she was doing great for a year, but then somebody tried to abduct her, so she got her PTSD back. So kind of makes sense.
I've wondered if there's an automaticity that ends up developing to the sympathetic nervous system if it's too overstimulated for too long.
What do you mean? It's self-feeding? Is that what you mean?
It just turns on and it keeps getting stimulated to stay on, so it just keeps staying on.
Yeah, but I think I said it more elegantly because I was talking about the fibers. I was trying to explain why the hell can it last longer. Yeah, I agree with you. Because as long as you have norepinephrine in there, you're always activated.
Yeah, so that's the automaticity piece. A lot of us treat pain conditions.
Right.
Speak to that a little bit if you can.
Sure. I'm a pain physician, so I look at the word from a pain perspective. So I think sympathetics, overactivity of sympathetics will give a couple of things. Its perception of pain is a big part of it. It's not, what's pain? When you hit your toe, then, okay, you hit your toe, big deal. But it's the burning part that really annoys you, right? So that is because a different type of nerve fiber got activated. It's a C fiber. So sympathetic fibers are B fibers, and those guys can transmit information. So if you can reduce the sympathetic tone, I think, and also if you're not as anxious, anxiety makes pain perception much more active. So if you can reduce the sympathetic tone and not be as anxious, I think people will feel much less pain. Also, muscle tightness and all this is highly connected, I think, to sympathetics. That's why what you're seeing is when you do stellate and people become more relaxed, more malleable muscles, and you can now stretch them out better and do all that kind of stuff. Also, requirements, like at least in my space, I used to write a lot of opioids. We do very little now for multiple reasons. But if you can read, I would say at least a third of the people who would see me didn't see me for pain, they saw me for anxiety, and they're using opioids to reduce anxiety. So if you can reduce anxiety, then you need the opioids. And opioids produce opioid hyperalgesia, which activates sensitivity to pain, which is the last thing you want to be doing. So it's the cycle. That makes sense?
Mm-hmm. That was something that was added into the regenerative procedures quite a few years ago. And sometimes people have a hard time understanding, yeah, your foot and ankle pain will do better if we relax this.
Right. I mean, if the whole system is more calm, right? So if you think about the sympathetic system, if you're running from the tiger, what is it doing? So you're just single-minded, your muscle on maximal tightness, you're trying to move as much as you can, and also it's constricting the blood vessels. Because if you get cut, you don't want to be bleeding to death, so the tiger doesn't get you. It's not very adaptive in what we're doing. There's not many tigers out there currently. There's not here.
I hope not to meet one.
Yeah, exactly. Maybe jaguar of the car, but nothing. That's about it.
Maybe a cougar, not a
Yeah, that's a different story altogether. Yeah, we're not going to go with that. We're just not going that. No. The other part that's kind of interesting is sexual dysfunction and PTSD. So I wrote a chapter on that, and turns out about up to 85% of men with PTSD have sexual dysfunction. And there is a norepinephrine chart, kind of interesting, the U chart. So not enough norepinephrine produces less interest in sex. Optimal amount is perfect, and too much sympathetics reduces sexual function, which kind of makes sense, right? If you're running from the tiger, you're not going to be thinking about the reproduction. You want to be able to keep running. Right, and you don't want anything sticking out because you're not aerodynamic. Can't be doing that.
Don't want to get caught on the thorns.
Or something like that.
So until a couple of months ago, after having done this for nearly 10 years, I couldn't tell people why injecting here affected the brain. So one of our early conversations was Dr. Lipov letting me know, oh, this is how everything is wired. So that was a revelation to me. So if you can tell everybody why injecting here actually infects the brain,
Sure.
actually that
Sure.
neurocircuitry, really important.
Yeah, so I mean that has always been, it's like, why would you do something here to affect the brain? And it's like, that makes no sense. So there is actually an article, somehow, somewhere, for some ungodly reason, people decided to study a connection of stellate ganglion to the brain. And the way they did it, they used rabies virus. So rabies virus is it likes to eat nerves. So they labeled rabies virus and injected into stellate ganglia in a rat. And then they sacrificed the rat, whatever, 3 or 4 weeks later. And they found a direct connection from the neck to the amygdala, which controls PTSD, and insular cortex that controls hot flashes and pain. So that's actually been shown, a hardwired connection from the neck to the brain. And the other stuff that I was talking about, sprouting and all of that, that's actually been shown experimentally in rats. Nothing in humans, but that's how we want to keep it, obviously. But yeah, so there is definitely a direct connection from here to the brain, which is, I think that explains why you can do something to it. Because short of that, it's crazy. Anatomy doesn't make any sense. And that paper I was referring to was published in 2001. But there was nobody was interested in that. So it was just sitting out there. Until I picked it up and wrote a little article. And here we sit today.
And looked at an anatomy book from 1956.
Exactly. Charles Moore, that was all in there. And that has not been published since 1972. It's crazy.
What about schizophrenia have you used it to treat?
Interesting question. No, that's a difficult patient population.
Yes.
If I was a psychiatrist, probably. The reason I find it interesting, there was a paper written in Japan in 2003. There was a schizophrenic that was riding a horse, fell off a horse, fractured his shoulder. They did 3 stellates on him for the pain. After the first one, so apparently one of his presenting signs was that the patient was, he heard nasty voices in his head, very diminutive voices. So after the first block, the voices went from nasty to polite or pleasant. After the second one went away, after the third one went away more, whatever that means. And he had the response to it. What's interesting, so the amygdala also controls schizophrenia. So theoretically it'll be used, but those are an interesting group to work with.
Yeah.
Do you think the psychotropics that they're on would make it a more difficult population also?
No, because, well, the reason being, so atypical and psychotic is the flavor of the month, right? Seroquel and Risorbital. A third of the military is on that.
Yeah.
And they treated them, and we were able to get them off. Now keep in mind, of all the drugs out there that are used, those are the most evil drugs in the world. The reason I say that, there's a couple of things. One, it has a few lovely side effects. It produces impotence, weight gain, breasts in men, which doesn't look so good on men, typically. It produces metabolic syndrome. It increases cholesterol. And my favorite one of the 1,000 per year use, the heart stops because they have a cardiac standstill. And it's still being used. It's like
What drug was that?
Sure.
Risorbital and Seroquel. Atypical antipsychotics. So I don't think atypical antipsychotics actually have anything to do with, first of all, they're not effective, but will it prevent efficacy? I don't think so at all.
So I have an N of 1 from about 3.5 years ago, that's schizophrenic.
Yeah.
He was able to, I only did 1 injection on him one site. He said it rewound him about 20 years.
So he felt better.
Yeah.
That's great. It's consistent with the paper from Japan. That's exactly right. So did his voices go away or whatever symptoms he had?
A lot less voices, a lot less.
Yeah, it's consistent.
He had auditory, but he had visual hallucinations as well.
It's totally consistent. And just, you need a different setup than mine to be able to deal with schizophrenics. That's a nuts. That's like a different level of psychiatry, right? That's. I'll let somebody else deal with that.
Question for you, it's like
Sure.
the tiers of what you can call PTSD, right? What are some of the most popular ones that you find? Like the bipolar, does even like borderline come into that ever? Have you had it with those? Have you had success rates with that? OCD issues, like,
OCD we have treated.
yeah.
So borderline personality is and personality disorder is a whole other story. So the people who are the best with stuff we do is when they have overreactivity, difficulty sleeping, those kind of things.
I feel like that's all in that though. I mean, like,
Borderline?
yeah, because they've had a trauma, like usually abandonment or something when they're young.
We see a lot of that, yeah.
Yeah.
We've seen a lot of. But borderline is totally different. So the way you respond in borderline, at least I've dated somebody who's borderline. Whew! If you want to have a fun ride, that's the way. That is crazy. So the point is that adaptation is so sneaky and crazy.
But I would imagine they have a lot of fight or flight stuff going on. 'Cause
No.
They can't even center on.
Well, that's a good question.
They're like running away from something.
Well, let's look at a couple of personalities. At least, again, I'm not a psychiatrist,
Yeah.
but I know a little bit about just enough to be dangerous. But if you look at antisocial personality and then borderline, to me they're similar in many ways. So if you look at, there was a study done looking at antisocial personality and then showing somebody being decapitated or something like that. A person who does not have that, the heart rate goes up, they start to hyperventilate. Antisocial, there is no response. So I don't think they don't have the same, they're in such a numbing place that I don't think, I think that's more of a vagus problem as opposed to sympathetic. So,
Well, in the fMRI, they usually have the lower activation.
I don't
Can you
know.
explain the differences between the vagus and the sympathetic for me?
Yeah, before I do that, let me give you a different answer. So, Steve Porges, who is like the best guy in Vegas in the globe, happens to be a buddy of mine, he wrote his big thing is we have two Vegases. There is the old Vegas and the new Vegas. So it's called Polyvagal Theory. So when somebody has stress, there is grades of stress. There is the first thing that happens when somebody is stressed, a little bit. Then the new Vegas gets removed and the heart speeds up a little bit. That's all that happens. Second phase, you have sympathetic kick in. Now, more increase in heart rate, more contractility, faster heart rate, right? Third is when the old vagus kicks in, and that's from the turtles. And the thing about when the turtle dives, they have a dive reflex. The heart slows down, everything slows down. So that's a vasovagal response. So what it looks like in humans is that a lot of people freeze, right? Soldiers, out of the soldiers, it is before NAM, before they trained them, one out of 5 would shoot at the enemy, everybody else would freeze, right? So the vagus is overwhelming at that point. So if you look at that, there was a study done, women during rape who would get immobilized because of fright, their PTSD would be so much worse than the ones who fought back.
Deeper.
Yeah, interesting.
Shock.
So that's where the sympathetic versus parasympathetic really work on. So when it's, anatomically, I'm not quite sure which nuclei we're talking about exactly, but the amygdala is one thing. Nucleus ceruleus is where sympathetic lives. Just if you look at top of the brain going down, so nucleus ceruleus is above, and I think in the pons is where the vagus sits. Something like that. I don't quite remember that particular anatomy. But the interplay between those. But like the borderline personality, those are very scary people to me. I don't think I'm going to be able to do much with them. They're so manipulative. It's just scary. Or antisocials, they're just scary people. And their adaptation, whatever, it's adaptation to something, right? But I really don't understand the whole thing. And we've tried a couple, and we do try to weed that out. We tell people, your chance is 50-50 at best. They go, well, we'd like to try. It's like, we'll try, but probably not going to work that much. Because you don't know what they're getting.
So we got PTSD, we got pain, we got sexual dysfunction, we've got
You said Raynaud's last night, things like that.
Say it again?
Raynaud's, like you were talking about.
Raynaud's, yeah. Yeah.
Sympathetic dysfunction.
Right, sympathetic overactivity, yeah.
And one of the things that I tell patients or discuss with them is all of us have had trauma in our life, and if you put in that wrong set of circumstances, you're going to react just like you have PTSD.
Right.
And, so instead of PTSD, normal being here and PTSD being over here in the definitions, it should be a range.
Right, you have to draw a line somewhere. It is a spectrum, but I think I think right now we're just getting to the point where I would say in 20, 30 years, you can be a routine equivalent of PET scanners, or not PET scanners, probably fMR, a wearable MRI, like a small band you put in the head and it scans you. So that's how it's going to be. Neuroscience and psychiatry are finally going to be uniting. Because currently psychiatry is a very soft science, but there's no reason with a neuroscience perspective, psychiatry can be dragged into the light. But once you see what's going on, it's like, oh yeah, this is what's going on, this is deactivation, this activation of this. We're going to see that. So
the other group of people that we've treated here are individuals who are growing, progressing, learning, and they want to augment that process. And we've had success with those individuals.
How do you define that success? What do you mean by augmentation exactly?
Let's see. What I get back from those individuals is a whole bunch of new options popped up in front of me. Things got a lot clearer. I knew my next choices. So these aren't people that are in acute fight or flight. They're not PTSD.
I would disagree with that. I think they are. But that's why. So that we've had actually, it's interesting, one of the people we treated is a filmmaker. And she said that the color is so much brighter. It's much more vivid, right?
Which is me saying that all of us have these things that we're carrying all the time.
Right. But my point is, you have I think it is a form of whatever, post-trauma effect. It's just not as clinically. You're not sitting in the room, covering yourself up as pillows, right? You're highly functional, but you can be functioning more when your sympathetic are kind of at rest or at bay. So we're saying the same thing. It just still.
Yeah, and one of our goals here then, and we talked about this earlier today, is we want to start that ball rolling by taking the sympathetic dysfunction down quite a bit, but then have intuitive healers, acupuncture, psychology working together to help people to continue to take step forwards and not just have a passive treatment.
Right. No, you have to participate. It's part of it. Absolutely.
Autism. Have you had any cases of that?
We have done a couple, and there was some improvement. I mean, is that like totally 100% solution? No. And there's a whole spectrum, right? So we took a guy who was nonverbal, and he was able to communicate better. The way he communicated with his mother was iPad. But his communication and being able to do his daily chores significantly improved. Tough population to deal with, but yes, sir.
Have you guys done any sort of like objective testing for looking at the patients who do respond versus don't respond to the stellate ganglion blocks, as far as like pupillometry or like heart rate variability, looking at any other like autonomic markers to determine why they may or may not respond to that outcome? Maybe there.
I really haven't.
Yeah.
You need resources for that, but that's why we're trying to do a functional MRI study, which would be like the gold standard. Pupillometry has downside, heart rate variability has a downside, military loves HRV.
Yeah.
It's not as dependable as you'd like, by the way. That's all Dr. Porges' work. That heart rate variability is his thing. And it's like there's going to be always debate about that. But that's why I want to look at the brain itself, which will be, that's really not debatable. That's much more measurable.
Is there any other looking into hypothalamic inputs included with the amygdala, HPA axis, the sympathetic outcomes that you guys are
How
looking at as well?
to, what do you mean?
Well, from like reading into neurology and neuroscience, the hypothalamus is heavily implicated with the sympathetic reaction, right? So you see something coming at you, you have the hypothalamus,
Right.
react with the pituitary, the adrenals,
They're all connected, right?
All that stuff. So, even just looking at markers for hormones, like oxytocin comes up into that area. Would there be any markers pre or post that you could look at outside of any of the fMRI studies that you're doing now to determine whether or not there are secondary outcomes as a result of that for your studies?
Maybe, I'm not sure. I mean, I'd love to have cortisol being recorded because cortisol, obviously it's adrenals, so there is a connection. HPV, that axis does interact. I wrote a paper about the interaction between that axis and sympathetic. I mean, they do talk to each other, obviously. But the beginning of the threat perception is amygdala, and then it tells everything else to do things, right? So then HPV axis gets activated, then you have adrenal kicks in more and all of that, and it cycles. So if you can stop the persistent activation or overactivation of amygdala, then theoretically everything else will resolve. And you guys have amazing tools now. You have, besides the stellate, you have the acupuncture, you have psychological intervention, you have all of that, exercise, which all produce effect. Yeah, absolutely.
And synergy is powerful.
Oh, absolutely. Yes, ma'am. Did you have a question?
How about, can you talk about oxytocin a little bit?
Yeah, oxytocin is pretty interesting hormone, actually. What I found is after you and I started talking, I knew about oxytocin, I never really looked into detail. So it turns out oxytocin is sympathetic, meaning it actually reduces sympathetic outflow, which makes sense, but I've never looked at it. And then you mix it into your mix. Actually, we're going to start doing that soon. And that seems to be a receptor in sympathetic ganglia for oxytocin, which kind of makes sense. If you're feeding a baby, you don't want to be riding from the tiger, right? You want to be calming down, producing more milk, not gaining weight, all of that stuff. So I think, and hugs help. That's a good thing. And also, it's putting into injectate and lozenges. I think that makes a lot of sense. Part of the reason I think everybody's so stressed out, not the only reason, of course, is because there is no interaction right now. So oxytocin level is lower just when we need it the most.
So it's a sublingual hug.
So more.
You got it.
More hugs before the injections.
It doesn't hurt. It doesn't hurt. But I mean, it makes perfect sense. But I had no idea that there was a direct anti-sympathetic impact of oxytocin. I've seen it used, it's like in OB when I did a lot of OB anesthesia, but I had no idea. Still don't know how you figured that out, but it's pretty cool.
Sometimes it just is.
The man from upstairs gave you a thought. From up high. Any other questions? I think we're almost done with our time.
Well, Dr. Lipov has upped my game today. We got to do about a half a dozen stellates together. Standard.
That's great to see.
Do them in 2 locations, so it's a more profound
Right.
sympathetic blockade now.
Yep.
And so
You're actually doing stellate ganglion block and the superior cervical ganglion. So they affect different part of the brain.
Signing up.
Well, he's here all day, I hear.
I know.
you can have injection parties.
Yeah, woo! Yeah, like Botox parties, the same thing? Nice, very nice. That's reassuring. Thank you. That makes me feel so good. Just have a rolling slate, right?
So sometime I want to talk to you about the possibility even of adding in like psychedelics into that equation.
I mean, there are people are playing with it, but I don't think I would mix it with that. I don't know. Maybe. I'm trying to be as pure as I could to this, because
another way to get to the brain.
Yeah, because I mean, there are. I mean, Hopkins is big into psychedelics, but psychedelics have their downsides. I don't know. I mean,
You're dumping a lot of serotonin.
yeah, I need to do permanent change. Sometimes the change may stick in the wrong way. I don't know. I'm just going to focus on things I know something about. I'm not going to be flying to the Mars and cutting out my male equipment. And we're not doing that. And psychedelics can send you in the wrong path, I think. They're not all trips are good, right? Once you do it, though, it's permanent. So the thing here we do is just putting local in. We're not doing anything that really changes the substance of the brain itself, which is, to me at least, is scary, but we'll see. Pharmaceutical company want to get next new drug on board here.
Yeah, if we could package what we do into a drug, it would be.
Yeah, it'd be amazing, but no, that's the thing. That's where the strength is. Yes, sir.
So, what are you injecting, and what is the cost? I'm assuming Dr. Hansen's doing these now, and then what are there any side effects? So those practical.
Well, that's fair questions. What we're injecting, so what you're injecting is either bupivacaine or ropivacaine, which is a long-acting anesthetic. I like to put in clonidine into it. You like to put in oxytocin and dextrose. But the main active agent is local anesthetic, long-acting local anesthetic. Cost-wise, you have to talk to him about it, see how you guys set it up. And as far as complications, so the reason it's done, so the question is, how do you do it? Do you do it with X-ray guidance, ultrasound guidance, or blind? I'm old enough to have done it blind. This was in 1990. So the most common complication is a little hoarseness, things like that. It's really not a huge complication, it's just mild discomfort. So if the needle goes in the wrong spot, well, let me preface that first. There was a study done in Germany. This is before ultrasound guides or X-ray guides. They did 42,000 of those that year in Germany. Nobody died. They had 1 out of 1,000 people had seizures. If you hit the artery, vertebral artery or other arteries, you can have seizure from that. I think 7 people had pneumothorax, air in the lungs, and then there were 2 allergic reactions.
Was that with X-ray guidance?
This is blind.
It was blind.
This is 1993. So since then, there have not been a big publication study, but the complications are 1 out of 200,000 can get an infection in the neck, and 1 out of 100,000 or 200,000, they can have bleeding in the neck, and that could be catastrophic because your blood vessel that is hit. That's why we use ultrasound and Doppler, so we can see where the vessels are. But that's basically the numbers. So 99.99% of complications happen in front of a physician, so you can deal with it, and it would be like a seizure. And then you can give medicine to stop that and all that.
Thank you.
Absolutely. All good?
This was great.
Oh, you're welcome. My pleasure.
Thank you all for coming in, Dr. Lipov.
Thank you for your interest.
Making the trip up here and spending time with us.
Oh, no problem. I've learned a lot. It's been fun. Had a nice time to visit. That was very nice. Have a good day, ma'am.
You say you're practicing in Chicago area?
Yes. Yes.
Where are you at in Chicago?
Where am I working in Chicago?
Is it Chicago proper?
Chicago proper, yeah. Where all the riots have been. Yeah. Yeah, I live across from Navy Pier, and I operate in a surgical center that's about 3 miles away. Yeah.
There's a group of angry people that need the injection then, huh?
Yeah, a number of people have left Chicago also, so we'll see what happens. I mean, there's a lot of societal level changes. It's funny, so before the election, I was on a few radio stations. One of them was in London talking about election stress disorder. It's actually a real deal. There was a publication about it in 2016, and I would say the last election was not as nasty as this one. So they said 25% of college students developed PTSD following 2016 election. So if you think about what's going on right now, there's perfect storm, right? You have the epidemic or pandemic, you have the election and uncertainty, and what's going on with the economy. We still don't know what it is. We haven't quite emerged yet even to look. So that's all, and there's no hugs, right? Nobody's giving each other hugs, which is a problem too. So oxytocin is reduced.
Yeah, which reduces our immune system.
That's right. That's exactly right.
I was going to ask one more question because
Sure.
I was in a car accident that gave me a mild TBI. Have you worked with anything like that as far as memory gain? Because I have a little bit of that.
Yeah, it's interesting. So we did see the first military guy we treated had TBI when he was shot out of the sky twice in Iraq, and then he was patrolling the street and bad things happened. So his memory did improve, and hippocampal function, it did improve following that. And then, the sympathetic fibers went down, but yeah, it does seem to improve the memory, so it'd be worth it. Yeah. Oh, you're welcome. Hopefully it helps you. I'm sorry. TBI is no fun.
So are you working on injections of the ligament structures of the back too? No, it's all cervical?
I'm not a regenerative doc like this fine young man is. I'm an anesthesiologist, so I do the old, my focus, I'm 62 now, my focus is going to be basically developing PTSD, making it available safely and well. But as far as regenerative stuff, I don't do that.
There's a lot of research coming out, is it brain versus brain? And a lot of symptoms that you would think is TBI is coming from the atlas, C1, C2 ligament damage. So
I believe it.
Upper cervical instability, Polyvagal syndrome.
So that's what I want to talk to you more about. We'll do that in our time.
I believe that. I'm not an expert in that.
Yeah.
You got to stick to things you know.
That was the condition actually that where I started to marry the two together all the time, was doing Polyvagal syndrome patients with upper cervical instability, always doing the sympathetics on them and doing the upper cervical stability work, and they were synergistic to work together.
So you, Ron, can you answer that question about if a PT and an SD, I got someone I want to send them, say today. They're going to call your front desk. What's going to happen? Cost, how long it takes, all that. Can you talk to that?
So an initial evaluation with me is about 2 hours. That's 400, and doing the double injection is 500.
Okay.
So each time I do this, the cervical sympathetic block, it's 500, and I try to do it as well and completely as I can for there to be the least amount of cost possible.
So I'm working with some military and PTSD, and there's the component that the mental would say, but then they're finding there's a spiritual that the military that they can't forgive themselves for
You mean,
what they
yeah,
did,
moral
overseas
trauma.
and
You're
stuff.
talking about moral trauma.
And they got to deal with that too. So but
Moral injury.
that's why I wanted to be here for this, because I like action steps. I just don't like to talk about something. So if there's people that we're trying to save from suicide, we got to say, here's what you do. Get up here and take this
That's why
treatment.
we have him. That's his work.
He does what?
You should share.
He injects cervical ganglion?
Well, so he does the injection.
No, he does
and then
injections.
He does the spiritual work.
Okay, good. Which one? We'll talk.
The ninja.
Yeah, so moral injury, there is a lot of stuff written about it. One of my actually partners, she wrote a book on that, so she knows a lot about that. So yeah, the moral injury is a real deal, and separation of that and PTSD, that's tough. That's not easy. Yeah, people, they want to be killers, but they're placed in a position they have to be. So
That was interesting what you said about parasympathetic versus sympathetic when crime or something's being perpetrated, if they're fighting, and then what PTSD versus if they're not
Shut
fighting
down,
and
yeah.
taking it on. Were you saying more effect on vagus on the parasympathetic when they're not fighting?
the reason they're not fighting because, so if you scare somebody,
To freeze.
right, they can do a couple of things. They can run away and beat the shit out of you. That's one approach. The second one is to go complete shutdown. That means their parasympathetic system overwhelmed the sympathetic system.
Yeah.
So, by the way, here's an interesting stat. You probably don't know this. How many possums die? What percent from playing possum? No, good question.
1/3.
Yeah, about a third of them will die from playing possum. It's not a trick. It's a physiologic response to severe stress.
So 2/3 effective.
Well, if they eaten when they were fainted, that's not helpful either. Is it? If the bear stomps on them, how helpful is
I
that?
just love parsing statistics.
2/3 effective to survival. At least you didn't die yet, right? But then you got picked up and eaten. What's the difference?
Cougar attack versus a grizzly bear attack. Two different responses to those.
Really? I don't know the difference. If you have a gun, shoot it.
Thank you very much.
And cookery, Ron.
Thank you.
Shannon,
Thank you.
Christine,
Nice to
good
see you, buddy.
ladies.
Shannon, someday I would like to get to meet you. We go to the same church, and I want to get to know what you can do over there in rehab.
Okay,
Yeah.
that sounds great. Yeah, we go to the same
Can
church every
I
day.
give you a
Yeah,
card?
please.
All right, everybody, thank you for being here. Awesome questions. Dr. Lipov, thank you so much for
Oh,
sharing your
my
experience
pleasure.
with us.
Thank you. Thanks everybody for coming. Hopefully it was interesting. Thank you. Thank you. Thank you very much.
I'm gonna be here twice this weekend.
said, let it go.
Cool.
Nice to meet you.
Nice to meet you, man.
Take care.
Good luck to you.
Thank you.
Thank you.
Hey, Doc.
Okay, so.
Hi
Nice to
there.
meet you.
Nice to meet you.
Awesome presentation, by the way.
Thank you.
I have a colleague in Chicago who works with